Well, good morning. So today I want to take you through this article from the Journal of Clinical Oncology. And what you'll see first off is that I have not logged in here. So I'm just showing you what's freely available to everybody on the internet. If you Google Journal of Clinical Oncology, and then you get to the website and you look up rhabdomyosarcoma in the last 6 months, that's at the time I'm dictating this, and you'll see March 7th, 2025, you can find this article. There it is, volume 43, number 16. And it's an article about rhabdomyosarcoma, and in particular what's called high-risk rhabdomyosarcoma. Now, I'll have to explain that later. When you hear high risk, a lot of the time your mind goes immediately to patients with metastatic disease, maybe lung or bone metastases, but within rhabdomyosarcoma it's a little different to neuroblastoma and some other tumours, where those patients tend to be what you call very high risk, and this is a different set of patients who are high risk according to the European risk stratification system, and I'm going to take you through that shortly. Anyway, this is an article from the European Paediatric Soft Tissue Sarcoma Study Group, EpSSG. See, there's their name down there, EpSSG. The European groups, like America has the Children's Oncology Group, which tends to take in most of the sort of huge consortia. In Europe, it's a bit different. There's SIOP, which is the Société Internationale Oncologie Pédiatrique, which has subgroups, SIOP-N for neuroblastoma. And then there's other groups which I never know if they're part of SIOP or not, or how they interact. But in any case, there's this European Paediatric Soft Tissue Sarcoma Study Group, EpSSG. And this is a trial where they looked at giving something called maintenance chemotherapy. So maintenance chemotherapy, we hear about that all the time in children treated for acute lymphoblastic leukemia, and that means we give them all the heavy-duty chemotherapy for 6 or 8 or 9 months, and then the maintenance chemotherapy is that phase of treatment with just low-dose oral chemotherapy, much less intensive, but it goes on for a long time, and that's well established in acute lymphoblastic leukemia as a critically important part of treatment. But what this study sought to address was whether adding in a phase of treatment like that would improve the outcomes in rhabdomyosarcoma. That is, after they gave all the usual heavy chemotherapy and radiotherapy or surgery or both, if they added on a 6-month maintenance chemotherapy program, would that decrease the rate of relapse? Now, what I'll do is next, I'll just take you to the actual protocol. Now, so I can't show you the full article here because I haven't logged in and it wouldn't be fair. But they do attach, if you scroll down here, the actual protocol. And so this is the big protocol that the doctors and nurses and everyone's working off for their as they treat children in this study. So here's the protocol. Here we are, EpSSG, and there's their logo. And it's for non-metastatic rhabdomyosarcoma, this protocol. The first thing I want to show you is the risk group stratification here. So if we go to page 28 over here, you'll see the risk group stratification. So here's rhabdomyosarcoma is also a bit confusing because it's not just about the size of the tumour or the whether it's metastasized or not. Firstly, there's a distinction between different types of rhabdomyosarcoma. So embryonal ones are more favourable, and this one here that I'm highlighting, alveolar ones, that's less favourable. It's called alveolar because under the microscope it reminded pathologists of the alveoli of the lung, but it's got nothing to do with the lungs. Anyway, so when you stratify rhabdomyosarcoma, you have to look at what subtype is it. Is it the embryonal form or is it the alveolar form? And the alveolar form is always a higher risk situation. But also it depends on where the tumour is located. So if we go past, here's the low risk group, by the way. This is one that's localised, the nodes are negative, it's not alveolar, it was only small, less than 10 years, and the surgeons removed it all at the initial surgery. That's the low risk group. As you go down though, you'll see that it matters where the tumour is located, right? So let's keep going. For instance, in this standard risk group, it has to be in the orbit, the head or neck, not a parameningeal site adjoining the skull and meninges, and it can be a genitourinary tumour but not a bladder prostate one. So it depends on the location of the tumour as well as the type of rhabdomyosarcoma, the state of the lymph nodes, and the patient's age matters. In the lowest risk group, it matters to be under 10 years of age. So it's quite a confusing thing, and nobody even in the committee normally knows it all off by heart, or maybe they do. But in any event, this paper was, see, here's all these different subgroups of the standard risk group, and here we go. Now we finally get to the subject of this paper, and this was patients in the high risk group. And so there's groups E, F and G, and let's not plough through them in all their detail, but you can have a look at it. But see here, anyone with an alveolar rhabdo, and it doesn't matter what group they're in, that's another discussion, that's automatically in a high-risk group. Or any patient who had positive nodes would get into this subgroup F, and subgroup E is patients with group 2 or 3 tumours. That means after the initial surgery or biopsy, there was microscopic or macroscopic residual tumour. That's the IRS, they're the Americans, the IRS group system is defined after an initial biopsy or operation to remove the tumour. And so if there's macroscopic disease left, that's when you've just done a biopsy usually, then that's a group 3 tumour. Or if the surgeon took out the tumour but left microscopic residual tumour, that's a group 2 tumour. So that's who these are, the ones with microscopic or macroscopic residual, but in these unfavourable locations. See, the extremity is an unfavourable location. Bladder, prostate, certain other sites, and nodes negative, and the tumour was more than 5 centimetres, or the age was over 10. Anyway, it's complicated, but that's how you get the high-risk group. So next here, I can show you the overall design of the study. So here we are at week 1. This is where standard treatment began in this study. And by the way, the randomisation that we're talking about here is over here at the end, where they add in a maintenance phase of 24 weeks or they don't. But there was another randomisation earlier in the trial as to what chemotherapy was given in those early months of treatment. That's not the topic of this publication, and those results would get reported elsewhere. But let's just go up at the top here. I think this is the more standard arm. So patients in this high-risk group would get treated with IV-A, ifosfamide, vincristine, actinomycin D. And that's IVA. And that's the standard in Europe. Americans tend to use VAC. That means the I is replaced with a C for cyclophosphamide instead of ifosfamide. Anyway, there it is, IVA, chemotherapy and 1, 2, 3, 4 cycles of that IVA chemotherapy. And then they might get surgery if it was suitable for surgery now to remove what's left of the tumour, or they might get radiotherapy given if it's not suitable. And then they would go on and get more cycles of IVA chemotherapy. And see that little asterisk? That means that actinomycin would be withheld if it was during radiotherapy. All right, so that would be standard treatment for a rhabdomyosarcoma in a high-risk group in this European consortium. So to give the IVA cycles, then to start local therapy with surgery or radiotherapy, and then to give more rounds of this IVA chemotherapy. And in the trial, by the way, they were looking at the addition of doxorubicin, which makes for more toxicity, but maybe it would improve the outcomes, and that's what they were looking to see. But I'm not talking about that today. And then that would be where treatment would normally stop, but in this trial, they would be assessed to check that the scans are still clear, that they've become clear or they're satisfactory. And then in patients who agreed to it, they would then get randomised to either call that the end of treatment or go on to the maintenance phase of treatment. And that's what the study's all about. Giving this 24 weeks of vinorelbine and cyclophosphamide, will that decrease the rate of relapse compared to just stopping treatment like might normally be done? Now, let me tell you what the vinorelbine cyclophosphamide treatment's all about. See, these are heavy chemotherapies, these IVA cycles. That's strong, heavy chemotherapy and, low blood counts and in hospital to give the drugs. And it's big and strong, as we use in rhabdomyosarcoma. Very justified by the data, of course. Now, the vinorelbine cyclophosphamide, oh, hang on. And that's the very high-risk group, by the way. That's alveolar rhabdo with positive nodes. I think non-randomly were allocated to just get the maintenance. I think that's what happened there. I'll check. I think they all got it and not in randomised fashion. So let's go back to the abstract. And so here's what happened. The patients were randomised to discontinue treatment or to receive 6 28-day cycles where they would get a vinorelbine intravenous injection on day 1, 8 and 15, and then day 22 they would have a break, and they would go on oral low-dose cyclophosphamide every day for the 24 weeks. So it was basically 3 weeks on, 1 week off of vinorelbine IV shot. That's a short, 5-minute shot through the central line or a vein, and oral cyclophosphamide. And that was given daily. Okay, now what happened was they reported the early results, the initial results in 2018. And I'm pretty sure this Dr. Bisogno here, the first author, is the one who presented them at the American Society of Clinical Oncology, and was such an important paper that it was presented at what's called the plenary session. That's the biggest session of the whole conference, which is usually dominated by adult oncology results, breast cancer, lung cancer, etc. But to get a paediatric paper in there is uncommon. But this result was so important that it was judged suitable for the plenary session. And we even went out for dinner and celebrated with these authors that night to congratulate them. Now, what happened in the initial results, they showed improved overall survival in the patients given the maintenance treatment. Overall survival. But when it came to disease-free survival, the improvement wasn't statistically significant. So disease-free survival means that the patient is alive and there has been no regrowth of the cancer. Overall survival means they're alive, But some of those patients will have had regrowth of the cancer and maybe have gone on to some other form of treatment for the cancer. So there are two different endpoints of such clinical trials. So in the initial results, there was an improved overall survival, and that was the big thing to present at the plenary session. But disease-free survival, there was an improvement, but it wasn't statistically significant. Okay, so now what they've done, now we have an extra 5 or 6 years of follow-up since then, and it's mature outcomes. So with longer follow-up, any differences may become more obvious or less obvious. So here we are. That's what this paper's about, the mature survival outcomes with extended follow-up. And here's the data. So 186 patients were enrolled in the standard arm and 185 in the experimental arm. They're the ones that get the maintenance treatment. And now with a median follow-up of 122 months, so 10 years median follow-up from diagnosis, and 114 months from random assignment. So remember, they were randomized at the end of frontline therapy. And what we see is that a relapse or disease progression or death occurred in 103 patients out of the total. What's the total? 186 plus 100, about 370 patients. 61 in the standard arm and 42 in the experimental arm. So the 10-year disease-free survival was 66.5% in the standard arm versus 77.1% in the experimental arm, and that was statistically significant. The p-value is 0.025. Got that? That's the bottom line here. The disease-free survival, if you added maintenance treatment, was 77%. Compared to 66.5% if you didn't. And that's a meaningful difference, and it's a statistically significant difference. If you look at overall survival, again, they showed a benefit to those given maintenance. 82.9% overall survival at 10 years compared to 70.8% in patients who did not receive maintenance, and that remains statistically significant. So this shows that there is a benefit from giving maintenance therapy with vinorelbine and cyclophosphamide to patients with high-risk rhabdomyosarcoma who were treated according to the EpSSG, IVA, radiotherapy, surgery, whatever program as the intensive component of treatment. And I add that in because this isn't to say that maintenance will improve outcomes in all regimens for high-risk rhabdomyosarcoma, but it did improve them in patients with treatment according to the EpSSG intensive elements of treatment. So that's a pretty significant finding, and maintenance treatment is more a leukemia thing, but here it is, apparently delivering benefit in rhabdomyosarcoma. And this is a very exciting result, and one that then leads to, well, what's the next study? Is 6 months enough, or is 12 months better? Does it work if you've had American-style VAC chemotherapy first? There's all sorts of questions, and the various rhabdomyosarcoma groups are out there trying to answer them. So there it is, pretty important paper, pretty convincing, well conducted. If you scroll down, there's the protocol that I showed you, and conflicts of interest and all that sort of thing. Okay, and I will leave it there, and see you next time.